Welcome to the Hologic Virtual Education Session, How to Successfully Transition NovaSure Procedures into the Ambulatory Setting. My name is Sarah Smith. I am the UK Surgical Marketing Manager and I will be your host this evening. Before we start, I'd like to cover a few tips about our virtual platform. At the bottom centre of your screen are several icons that will help. Each of the windows on your console can be resized and repositioned, so feel free to move them around to get the most out of your desktop space. For example, if you'd like to expand the slides window, you can maximize it to full screen by clicking on the arrows in the top right corner. If you have any questions during the session, you can submit them in the Q&A window. If you don't see the Q&A window, select the round icon on the bottom center of your screen, indicated with a question mark. We have a Q&A session at the end of our two presentations and will answer as many as possible. We also have a team supporting the program today, so please use the Q&A function if you require any technical assistance. You will have the opportunity to access your certificate after 30 minutes of the live webinar, and you will also receive a link in the follow-up email after the event. Finally, an on-demand replay of the webinar will be available and can be accessed using your same registration link that you used to join today. We have placed some useful resource materials in the resource list window that we would encourage you to download during the session. We're delighted to have two guest speakers join us this evening, Mr. Martin Underwood and Mr. Peter Scott. Mr. Underwood is currently the Care Group Medical Director for Gynecology and the lead for colposcopy within Shrewsbury and Telford NHS Trust. He was involved in setting up the ambulatory service, introducing NovaSure and other outpatient procedures, and runs a very successful service. Mr. Underwood is also an Honorary Research Fellow at the University of Birmingham. Mr. Scott is based at the Derriford Hospital in Plymouth and supported the development of the outpatient hysteroscopy service, introducing both NovaSure and MyoSure procedures. He has also trained two nurse hysteroscopists who now support the service. You can read their full biographies in the speaker bio window. Before we get started hearing from our guest speakers, we would like to invite you to participate in our first poll. The question is, do you currently perform NovaSure procedures in the ambulatory setting? You can answer yes, no, or not currently using NovaSure. So just wait a moment for a few responses. A few more coming in now. Great, well, we can see the majority of the audience today do not currently perform NovaSure in the outpatient, so hopefully you'll learn a few things from our guest speakers this evening. So without further ado, I'd like to introduce our first guest speaker, Mr. Martin Underwood.
Hi, I'm Martin Underwood. I'm a consultant gynecologist at the Shrewsbury and Telford NHS Trust. I've been asked to talk about how we successfully transitioned NovaSure into our ambulatory care setting and its use during the COVID crisis. So why do we recommend NovaSure to treat heavy menstrual bleeding? Well, we know it works and there's good patient satisfaction. That's demonstrated in our own audits, but also in lots of publications around the world. We know it's a safe procedure, and again, there's lots of evidence to back that up. It's a very quick and easy procedure to perform, but also to learn and to teach others. Patients can get back to normal activity much quicker than those undergoing a hysterectomy, and there are numerous publications to support all of this. It's also the only radiofrequency device recommended by NICE in their guidance issued in 2018 for the management of heavy menstrual bleeding. So prior to 2014, everyone in our trust would have an endometrial resection or a hysterectomy if they were going down the surgical route. At that point, we were 2 hospitals, but 1 trust, and we were moving from Shrewsbury over to Telford to our new build unit. So this was an opportunity to expand our ambulatory care unit. Added to that, we had daily bed pressures with lists being cancelled and growing 18-week pathway breaches, but the patients had waited too long for their surgery. And we also had a keen body of newish consultants who were keen to introduce new procedures. We introduced NovaSure in 2014, and we went straight into our outpatient setting with this. So we did not routinely use it in the general anaesthetic setting. When we initially introduced NovaSure procedures, we started off with just 3 cases per list, but within a week we'd built up to 6 NovaSures each morning, as the doctors and nurses picked up the procedure very quickly. We had a great deal of support from the Hologic initially when we first started using the procedures, and now we offer training to other people who can come to our unit or we go to theirs to teach them how to do it too, along with the Hologic team. The main limitation when we first introduced it was that we were based at Shrewsbury in the few months prior to moving to Telford, and post-procedure space was the main limitation. In our new unit, that's no longer an issue. When you're introducing these new procedures, you obviously need to get your nurses on board and try and normalise everything as much as you can. You also need to inform the patient that this can be an uncomfortable procedure. We can stop at any point if we're asked, but we've never needed to. They will have a mucky discharge for 4 to 6 weeks after the procedure, and they may get bits of bleeding for the first few months following the procedure too. But generally the bleeding will settle down, and most patients will be amenorrheic or scanty bleeding after they've had the procedure. I also advise them that it can take around 90 seconds on average to complete the procedure, and they can get some period cramping, discomfort and pain during this. But in the long run, if we can stop their periods altogether, then it's worth the procedure. The flow of our patients, this is the new maternity unit based at the back of the Princess Royal Hospital in Telford, and the patients all enter the building through here. Once they're there, they'll come through to the waiting room, which is just to the left of the door, where there's a separate changing room for the patients, and then into our nice ambulatory unit where we can perform the hysteroscopy, MyoSure, NovaSure ablations. We also perform colposcopy in here too. We have 2 of these rooms available to us, and they're purely for the obs and gynae team. Once the ablation's been completed, they'll then go into the waiting area. And you'll see there's no beds in this area, it's all reclining chairs. And the patients are encouraged to get up quickly following the procedure, have a cup of tea and some biscuits, and then they go home around 20 minutes following the procedure. In the UK, we pay surgical sessions in PAs, and we would offer 1.25 PAs for a session, which equates to around 5 hours of time. This includes seeing the patients prior to the procedure and performing the procedure and tidying up any admin afterwards. We start our list at 8 o'clock in the morning with first 4 patients arriving then, and then we'll have a further 2 to 4 patients arrive around 10 a.m. so we can stagger them apart. If we're performing just NovaSures on the list, then we'll do around 6. If we have a mixture of NovaSure and MyoSures, then we'll do around 8. This varies by the speed of the doctor though. All of our patients prior to coming through for the NovaSure procedure will have been seen in the gynae clinic and have consent taken and information leaflets provided, and then this will all be reconfirmed on the day. The nurse or the HCA will conduct a pregnancy test for everyone, but we only dip the urine for urinary tract infections if the patient's symptomatic. And if it's a positive urine dip, we'll send off an MSU, but also provide antibiotics. But if it's a negative urine dip, then we'll proceed with the procedure. We don't routinely do any MRSA swabs on these patients, and since COVID started in March, we're not performing COVID swabs on these patients because it's all classed as an outpatient procedure, and we're only COVID swabbing those patients that are admitted. We do encourage everyone to eat and drink as normal prior to coming in for the procedure. We provide them all with the pre-meds, which we'll go on to shortly, whilst they're in the waiting area. And then we provide them tea and biscuits while they're waiting for the procedure too, to try and relieve some anxiety. In the waiting room, we also have a TV on and some magazines available. We do advise that the patients have someone drive them home following the procedure, purely because we offer Oromorph during the procedure or prior to the procedure, and this can make some of them a little drowsy. When we look at the medication, when we first started these procedures 6 or 7 years ago, we initially used paracetamol and PR diclofenac along with a cervical block and had pain scores of 5 to 6 out of 10. Shortly after that, we added in tramadol and the pain scores reduced to around 3 out of 10, but we found we had more nausea in our group of patients. And then around 6 months after starting to use the tramadol, the trust withdrew tramadol from the trust altogether, so we could no longer use this. We then went to meet with our pharmacy team, who were very keen to help us, and they suggested we use Oromorph, 10 milligrams orally, diclofenac 100 milligrams orally, and ondansetron 4 milligrams orally. And these all have a peak around 45 minutes after administration, so we try to time it that the patients come through around 45 minutes after we've administered medication. We also do a cervical block using 3 ampules of Cytonest, and I split that around at 12 o'clock, 5 o'clock, and 8 o'clock on the cervix, using the dental needle and getting it as deep as we can. We also use 2.5 milligrams per mil of chirocaine, and I use around 5 to 6 mils of this for the fundal block, and we'll see a video on that shortly. This has left us with pain scores of around 1 to 2 out of 10 for most patients. Got a little video of the fundal block coming up shortly, and you'll see that I use a 5 mil Luolox syringe, which is overfilled with chirocaine. I'll inject 2 mils by the patient's left ostia, around 1 mil just to the left of the midline, a further mil just to the right of the midline, and then the final 2 mils by the patient's right ostia. This uses a Cook's-Williams needle, which has a tip that is around 8 millimeters in length, and we try and get that as deep as we can, and then we'll inject that. So the video should be starting shortly. So on the screen, you can see the patient's left ostia, and that's the Cook's-Williams needle, and the metal tip goes all the way into the myometrium and the endometrium, and we're just injecting 2 mils. I would suggest you use a Luolox syringe. If you use a normal one, it will blow off because there's quite a lot of pressure that you need to get this through. Some of my colleagues that have smaller hands will use a 2.5 mil Luolox syringe, and then they'll fill it twice to get the local anesthetic in. So that was just to the left of the midline. We're going to go just to the right of the midline, and we use the Stort 30-degree offset scope. And just by rotating the light lead, the needle will slide across the top of the fundus nicely for you. And in a second, we're just going to distend up, and we should identify the patient's right ostia, and we'll inject the last couple of mils of chirocaine. So that's the fundal block. And the fundal block's been very useful at reducing after pains in particular for the patients, getting them on their feet and home much quicker. In a second, you're going to see a video for an outpatient ablation. We perform master classes where we'll do live surgery with colleagues in the lecture theatre, and the images and the videos are beamed across. And you'll see a patient who's about to undergo a NovaSure ablation. You'll hear the cavity check pass initially, then we'll perform the ablation, and then at the end, we'll do a cavity check. You'll hear how myself and my team are doing the vocal local by trying to distract the patient, talking about holidays and Christmas and so on. At the end, I do ask her a pain score, and she says 2 out of 10, although on the video it's not very clear. And to the left of the patient, you won't be able to see it, but there is a HCA who's trying to distract the patient too. So at the moment we're performing the cavity check, and this is distending the cavity to make sure there's no leaks or perforations prior to us proceeding. The patients are awake and they've all had diclofenac and Oromorph and a Dancertron.
Yeah, so it's past.
And you'll see there's a nurse to my left.
You hear the gas leaking initially around the side of the cervix.
He's testing up the scope.
So I've just pinched the angle of the cervix on the right.
Yep.
And we've passed the cavity check now, and then we're off.
And I'm actually talking to people who are in the lecture theatre as this was recorded during live surgery.
Yeah, I've got a week off in August.
Should we try then? It's going to rain all next week.
Oh.
So you'll get the sun. I'm going away, I'm going to get all wet.
Oh, good.
Have you still got any kids at home, or have you managed to evict them all?
Oh no, we're all grown up.
Yeah, how old are they?
My youngest is 23.
Yeah.
My eldest is 33 on Monday.
33. Yeah, and they got any grandkids?
Yeah, I've got 9.
9?
Yeah.
Children. How many children do you have?
5.
Oh, that's going to cost you at Christmas, isn't it?
Oh, it does. It costs a fortune.
Yeah.
One of the questions is, what is the space for now?
So what would your pain score now? Finished now, by the way.
2.
2?
Yeah.
Okay, so we've finished. It's 43 seconds.
Okay, so that's the ablation, and you heard she had a pain score of 2 out of 10. When we do the live video surgery, there's a colleague at the other end who's asking questions for the people in the audience, so that's the other voice you would have heard. After the ablation, we like to look into the cavity to make sure that we fully ablated the cavity, and also if we get good distension, it confirms that we haven't perforated the cavity anywhere. We've done lots of the procedures and we've not had any complications. And hopefully this video will play. So we're looking into the cavity. When you first go in, you'll find quite a bit of debris in the cavity, and sometimes it's just a case of irrigating that debris. And then we'll head up in a second just to make sure that we've seen both ostia. We've got fairly good views of the cavity, and you can see it's been ablated along its full length there. In a second, you're going to see a video for some patients that have undergone a NovaSure ablation. They come straight into the waiting area where we give them tea and coffee. These were NHS patients that were performed at the Nuffield as we had waiting time issues initially, so that's why the setting looks different. These videos have all been performed about 10 to 15 minutes after the patient's undergone the ablation. Hopefully it's going to play. There we go.
It was easy. It was what I expected. It was it was quick, and everybody that was in there was very reassuring.
Didn't realise it would be so quick and so, well, not painless, but I thought it would be a lot more painful than it was. Feel fine, just like I can just get up and go and carry on with my day, which I wasn't expecting. Hardly felt pain, just a discomfort. Just a little bit of a, ooh, what's that? You know, but nothing that I would call pain.
It's a quick procedure, and it seems like, I know it seems quite easy to me because I'm lying down and people are doing all the stuff below, but it seems like, you know, a better option than actually being stuck in theatre for hours on end or whatever, and then being stuck in hospital, and then, you know, all the anaesthetics and that kind of thing. Because I didn't really feel anything when it was going on. Yeah, yeah, I was aware of them being put in, but not to the extent where I would have kind of screamed and said, no, please don't do that again. Yeah, it was definitely discomfort rather than pain.
As I say, minimal discomfort, and hopefully no more periods. So that to me is a massive plus. The other option for me was a hysterectomy, whereas this is so quick, less invasive, less risky. I definitely think if anyone had the issues I've had with bleeding, that this would be the best option.
I would say probably 2, maybe 3. More discomfort. It was more discomfort than actual pain.
A 1, yeah. Hardly felt pain. Just a discomfort. Probably about a 2 for me. It was just a little uncomfortable more than anything else.
So you can see it's a well-tolerated procedure. We do the vast majority of our NovaSures under local anaesthetic. From the trust perspective, we don't have to have inpatient beds. From the patient's perspective, it's been demonstrated to be safer. And there's publications that have confirmed that patients who have procedures under ambulatory care compared to general anaesthetic have less hospital-acquired infections, less VTE, and less complications. We do offer them under a general anaesthetic if the patient requests that. That's generally the patient who won't tolerate a speculum examination at all. The vast majority of patients, more than 95%, would have a local anaesthetic NovaSure ablation. From our paperwork point of view, we try to standardise everything as much as possible. So on the left of the screen, you'll see our operation sheet. We've got the GMC numbers and the doctor's names, and then we pop a label down. The middle sections will inquire about pregnancy tests, have they tried Marinas in the past, current contraception, medical history. And then towards the bottom, you'll see if the boxes we tick regarding whether it's a straightforward ablation and any follow-up or not. We don't routinely follow any of our NovaSures up now. We discharge them all. And then to the right of the screen is our standardized pre-printed consent form, which we'll use for patients. And again, it speeds up the whole clinic process and standardizes everything. From our audit data, initial first 100 patients a few years ago, we had 94 responses and all the patients were contacted via phone. They had pain scores of 2 to 3 out of 10, but notice our analgesia has changed slightly since then, so it's improved. We had 2 patients readmitted out of that 100. One patient had a urine sample sent by the GP a day prior to the procedure, but hadn't let us know, and returned with some pain and discomfort, had a positive urine dip, and then in her MSU, a urine sample confirmed a urinary tract infection from a day prior to having the NovaSure, so she went home the same day with antibiotics. One other lady was admitted later in the evening after the procedure and was admitted or observed overnight and discharged in the morning. And the only positive finding was bacterial vaginosis on one of the swabs. So we don't routinely offer these patients any antibiotics. It's simple analgesia. And when we send the patients home, we don't send them home with any analgesia from the hospital. We just advise them all to take paracetamol and paracetamol and ibuprofen around 4 hours after the medication we've administered. We had an amenorrhea rate of around 70%, and to date only just under 5% have gone on to have any further surgery. I'd like to thank you all, and I'm going to hand you back to Sarah.
Great, thank you so much, Mr. Underwood. That was really informative. So before we move on to our next speaker, we would like you to participate in our second poll for this evening. And the question is, what is the main reason that has prevented you from moving NovaSure into the ambulatory setting? So the options are clinic setup. So this is kind of the main reason. So I'm sure there's going to be a few, but the main reason that's prohibited you from moving into the ambulatory setting. So clinic setup, pain scores, have not considered this before, have tried before but had a bad experience, or not adequately trained. So if you could respond to that. Not sure everything's coming through at the moment. You can see some results here. So it looks like the majority have clinic set up, so not maybe the optimal facilities at the moment. So I'm now going to hand over to our second speaker for the evening, Mr. Peter Scott.
So, hello. So, yeah, my name is Peter Scott, one of the consultants in Derriford Hospital in the southwest of England. It's just a photo of our hospital, which is a teaching hospital, as I said, in the southwest. Our clinic setup is very similar to Dr. Underwood, except our unit is a bit older and so our space is a bit less. So we have a separate consulting room, and then a separate treatment area which is attached to that treatment room. This is a picture of the stack, so you don't need a huge amount of equipment, but a monitor, something to be able to take photos, the camera, and a light source, and a printer is often very helpful for printing out the photos. This is a photo or two photos of the area. So for those who don't have a huge area or a huge room, it just shows that you can perform it in a relatively small area. And we perform colposcopy in this room as well. So there's room for the stack on one side and the trolley with all of the equipment on the other, and a bed. And the most important thing really is a decent bed with leg placement holders so that you can get adequate access. So our journey moving to the outpatient setting, we did this in about 2013. We were already performing NovaSure's under general anaesthetic, and it was working well. And it was put to us that perhaps to perform it in the outpatient setting. And I think we did start with a bit of trepidation, thinking the pain scores would be quite high. But we made the leap. Initially, we did some in the main theatre where we were doing them under general anaesthetic and used the local anaesthetic there. And we took our theatre nurse teams from the outpatients to there to learn the procedure and gain confidence. One of the main things we had to have was access to a recovery bed. And again, that can either be on the ward or in the outpatient setting in one of the other rooms. So we don't have a dedicated recovery area, but we've made do. And actually, it's very rare that we need to use that recovery bed, which is reassuring. And the whole move of moving NovaSure into the outpatient setting has been helped by the Department of Health tariffs, which have incentivised outpatient procedures. And for NovaSure, we found that actually there is only one code for NovaSure, whether it's done under general anaesthetic or as an outpatient procedure, as long as you have access to a recovery bed. So most of our patients are actually on screen or on the system, admitted and discharged, and that works well with the funding of the procedures and keeps our managers very happy. So the impact of COVID-19 really has, if anything, we've been doing more procedures in that outpatient setting. We have had a knock-on effect on our theatres with less theatre time. Patients have not been wanting to be admitted and come in. So overall, our numbers have increased in the outpatient setting. There are fewer people contacts with just the doctor and two nurses. As I said, we've got much shorter waiting times compared to our theatre cases. And it's quite advantageous that these patients don't need COVID swabs as it is in the outpatient setting, so they're not needing to come in 2 or 3 days beforehand for the swabs, waiting for the results and then being booked. And for our patients, they're in and out of the hospital quite quickly. They tend to come in an hour before for the pre-meds, and then in for half an hour into the theatres or the outpatient suite, and then usually home within that 20 minutes to half an hour afterwards. So it is quite a quick visit. So as I said, our clinic setup, we don't necessarily run 6 NovaSure cases all together. When our patients come to the top of the waiting list, we mix them in with our general clinic. So we're normally seeing about 6 to 8 patients in a general clinic, and we book them a slightly longer appointment if they go undergoing a NovaSure. So we do have quite a mix of patients. They do arrive 60 minutes beforehand for the pre-meds, and then they can go off for a cup of tea, cup of coffee or a bun, and then come back for the actual procedure. Staffing wise, we have 1 trained nurse and 1 healthcare assistant. So the healthcare assistant is there mainly as the vocal local, holding the hand and looking after the patient and making sure they're comfortable. And all of the patients, we try and give an information leaflet so they know what they're having and what they're letting themselves in for, and how it all works. And all of our patients, we do take written consent for the notes. As part of that written consent with the counselling, I think it's important to note that with the local anaesthetic that they get, sometimes that can get the uterus is quite a vascular organ, so it gets into the bloodstream quite quickly, and so sometimes they complain of their ears ringing or a slight woozy feeling of the head, which is very short-lived, but if the patients are expecting it, then they don't worry. And also reassuring the patients that the cautery takes 60 to 90 seconds, so it's short-lived, so even if they are slightly uncomfortable, it is very time-limited, which they find reassuring. And also letting them know that it can be stopped at any time should they ask. Not that we've actually had to do that to this date, but I think it's important that they know they can. And finally, and we'll come on to this later, but some of the patients in the outpatient setting we found can get a bit of increased pain later on in the day once the local anaesthetic is worn off. I mean, they're advised to continue to take regular analgesia throughout that initial day or so, but just letting them know that sometimes they're getting a bit of increased pain and that not to worry. And it's a bit like going to the dentist and having the local anaesthetic wearing off when you've had a tooth operated on. So our pre-med regime, it does change or has changed a little bit over time, but we give them 1 gram of paracetamol. We give them some non-steroidals. And at the moment, we're still giving antibiotics to all our patients. We have occasionally had a post-operative endometritis, an infection, and we've just found that since doing that regime, we really haven't had any problems with post-operative infections. So we've continued with that, but it not everybody does, and it may not be necessary. The analgesia regime within the setting, so we put a Cusco speculum in, have a look at the cervix, and then use tyrocane into the cervix with a dental needle. And we use 3 vials of that. Each vial is about 2.2 mils, and I put that into about 6 places on the cervix. Initially sort of at 12 o'clock where the cervix is held, so that's nice and numb, and then injecting around the cervix. And often going in quite superficially to start with, injecting along the needle track, and then ending up with most of the anaesthetic going quite deep, I think is quite important. And that does work well. And injecting slowly works well. We also use the fundal block using exactly the same Williams needle from Cook Medical, and we use 8 mils of bupivacaine in 4 areas across the fundus, as you saw in the video, near the ostia across the top, and then near the other ostia, and about 2 mils into each area. Some people use 5 mils, some use 4 mils. We found that 2 mils in each area gives us a very good anaesthetic. So that's just a picture of the Williams needle with the 8mm tip. So that the way that's designed is that you can't go too deep, and it doesn't perforate through the top of the uterus. So people should be reassured that it works really well, that needle, and it is quite flexible. And in our unit, we use an alpha scope with an operating channel. The reason I use this is it's only about a 2mm scope. It's very narrow, and our initial hysteroscopy gives us a good view of the uterine cavity without any dilation. You don't get any fluid leaking, and you get good distension of the uterus to inject the local anaesthetic under direct vision, and that does work well. So we've done a number of audits. Our first audit was looking at patient feedback and how they perceived the procedure, and 90% of women did get an information leaflet, so they knew what they were having. 83% of women had an improvement in their symptoms, either becoming amenorrheic or a significant reduction in bleeding, which was reassuring. 50% of women were back to complete normal activities within 2 days. So you can reassure, some of our patients were, some returned to work after the procedure, but most took a day or 2 off just to recover. And 88%, almost 90%, had all gone back within a week. So that's all very reassuring for patients, with giving them that sort of information to know what to expect. 80% would have recommended it in the outpatient setting to a friend or a relative, which was again very reassuring to us. And there was no correlation between pain experience and the length of treatment. So some patients end up with a minute and a half, slightly longer, and that didn't seem to increase the amount of discomfort that they were experiencing. So 90% of our patients were satisfied or very satisfied with the overall experience, which is, really quite high for most medical procedures. So, should give people confidence that this is really quite the way forward. And that there was quite a significant difference once we introduced the fundal block. So initially, without the fundal block, we found that maybe 60% were finding it, a reasonably good experience, but this increased significantly up to 81% once that fundal block was introduced. So if you are starting this in your own setting, then I'd really commend that William needle and the fundal block for your patients, which is an easy technique to learn. And then we went on to just this last 6 months perform a second audit where we were looking at sort of pain scores for both patients having under general anaesthetic and local anaesthetic, and looking at the initial pain scores at sort of just immediately post-procedure, and also between sort of 6 to 8 hours after the procedure to look at any comparison from there, just to give us an idea of what was happening once patients were going home, which I think is important. So we just looked at 9 patients in the outpatient setting and 9 day cases between March and September. So this is very recent. And patients scored their pain on a visual analogues scale. The medications given for the outpatients is as already described, with the paracetamol, brufen, and augmentin, with the local anaesthetic block to the cervix and fundus. The anaesthetic and pain given to the inpatients varied depending on the anaesthetist, so that was not standardised. But we were able to look at all of the pain scores afterwards. And what we did find was that overall the average pain scores for those having it in the outpatient setting was around about 2.6 immediately post-procedure, and was slightly higher for those having it under general anaesthetic. So just showing that cervical block and this fundal block does work really well. What we did find is that the pain scores at 8 hours post-procedure did increase slightly and was slightly higher for us in the outpatient setting. And therefore, we're changing the way we're doing things slightly now with our protocols of sending patients home with slightly stronger analgesia and having access to either cocodamol or Oromorph, with just being able to take 10 or 20 mils in a take-home bottle from that, which we were able to prescribe and keep within the department. So that was quite interesting, but overall, again, was all very reassuring that what we're doing is safe, is well accepted by the patients, and that most of them would be recommending it to their friends, and were pleased that they went through the procedure. And just to finish now, just a few suggestions that have made our NovaSures possibly slightly more successful as we've gone down the learning curve. As I said, we do our initial hysteroscopy with no dilation, so that you get good distension and no leakage of saline, so that you can really see where you're injecting the local anaesthetic. Once we do dilate before putting the NovaSure device in, we only go to H6. So again, you get a good gas seal, which is important. And it's important to accurately measure the uterine length to ensure that the maximum surface area is ablated to maximise the amenorrhea rates and improvement in their symptoms. It is important to get the wand position correct and to follow the NovaSure seating technique. And one of the issues some people have is getting the ears of the NovaSure stuck at the fundus. So it is important just to be able to pull it back a bit so that it opens up nicely into the cavity. And most cavities are reasonably wide, about 3.5 centimetres. So if you've got a very narrow reading, sometimes it just needs to try and redeploy it. It's important to rest it against the fundus while doing the procedure. And that then again helps with the overall success rates. So yes, I commend it to you. It is a little bit of a journey. It's important to take your nurses with you on this journey, and they'll be very supportive. And it's very rewarding for both the staff and the patients. And yes, hopefully you'll be able to take this on from here. Thank you very much. And I'll hand it back now to Sarah.
Great, thank you very much, Mr. Scott. That was a great overview of your experience. So before we open up the Q&A session, I'd like to invite you to participate in our final poll. So the question is, now you have reviewed the presentations, will you consider introducing NovaSure into your ambulatory setting? And the answers here are yes, within a sort of 3 months, so quite soon. Yes, within maybe 6 months, maybe within the next year, or you're already doing it in the ambulatory setting, or no, you're not considering this at this point in time. So if you just like to pop your answers in and we'll get the results through. Great, okay, we'll have a look at those results. So great, so it looks like many people are motivated or in progress to transition into the outpatient, so that's great news. So before we go into our Q&A, I would just like to promote our next webinar. So in just 2 weeks' time, we are having another event, a free event in the evening at 7 o'clock British Summer Time on the 8th of October. And this topic will be sort of related to NovaSure, an extension of what we're going to talk about today around common questions and misconceptions. So if you would like to join us for this free event, then you can register using the link that will be in your follow-up email that you will receive later this evening after tonight's webinar. So on to our Q&A, and we have quite a few questions that have come in. So we'll get started, see if we can answer as many as possible. So hopefully our speakers will come back and then we can answer a few questions. Martin and Mr. Oh, there we go. Perfect. So we've got everyone on the screen. Perfect. Okay, so let's start with a question around capacity, which I know is of importance at the moment around COVID to reduce backlog. Mr. Underwood mentioned that you are currently treating 6 NovaSure procedures in your clinic. And I know that there's a variety depending on resources and staff. So I just wanted to touch on that. So Mr. Underwood, if you can just give us your thoughts around how you've set that up.
I mean, from a capacity point of view, the turnover is very quick. The main thing is normalising it for the patient and telling them you're going to have the NovaSure, will be uncomfortable. We do want you up within a few minutes and having a cup of tea and then off home. The capacity-wise, if we were doing these under a general anaesthetic, we'd struggle to get through 6 or 7 cases on a general anaesthetic list, particularly the turnover at my trust. If anyone's worked here, the theatre turnover is remarkably slow. During COVID, prior to COVID, we were 14 or 15 lists every week for general anaesthetic. And then our ambulatory care unit does around 8 lists every week for ambulatory care. And then colposcopy on top of that's another 12 lists every week. But during the COVID crisis, we've dropped down to 6 lists every week for the general anaesthetic from around 14 or 15. And those are all focused on the cancers and the urgents. So if you're a routine patient waiting for a procedure during the COVID, you may wait a year, the current crisis, or longer if you were on the list for a hysterectomy. Whereas if you're a NovaSure, the waiting time's not really changed. We're still getting through them quite quickly. So it's just much more efficient use, and you have less staff in theatre. When we look at model hospital data, I don't know if anyone looks at this, I'm a nerd, so sometimes I look at it, but the national average cost for an ablation or a resection in theatre, if you're using a TCRE, is around 1,800, and the same for a diagnostic hysteroscopy. Whereas when we do it in the outpatient setting, I think it's around about £200 plus the cost of the device. So you can see it's significantly cheaper to be doing these procedures in the outpatient setting as well, compared to the main theatre setting. I've been pinging through and answering some of the questions. Sorry, go on.
Just to touch on that staff, I know you mentioned about having your healthcare assistants and nurses. So how does that work with the number of support staff that you have?
So we started off with lots of staff and we've slowly culled them. Obviously, we have very few staff now. So we have to have a nurse in the clinic because we're issuing medication. So that's the main step. And then we'll have a HCA who sits in a corner called the vocal local, who's there to distract and chat to the patient. So the nurse will do the pre-meds, but then we'll set up the scope and just make sure the doctors are behaving themselves. And then the HCA does the vocal local. And then outside the room, we have another HCA who's doing the urine dips, collecting the notes together at the end of the procedure. So we've trimmed the staff right back. Some days we'll have extra staff because we do lots of teaching. So we'll have extra staff floating through and rotating around the department. But they're there for more education. The only thing to bear in mind that our recovery area, the nurses also cover the acute admission. So if you come in as a possible ectopic, for example, you'll be in the same recovery area. So that nurse who's looking after the acute admissions can also keep an eye on our patients for us after. But we don't do blood pressure or anything like that pre-op or post-op on any of these patients.
Great. And Mr. Scott, your experience of how, from staff and resources that you've just set up the clinic?
So again, I mean, financially, I would agree that it's a complete winner. We earn the same for doing the procedure if it was under a general anaesthetic as in the outpatient setting, and the cost of performing it in the outpatient setting is a fraction of the inpatient setting. So that works. Our setup is almost identical to Mr. Underwood's, except we have trimmed it back to one nurse and one HCA, and most of our patients go home from the consultation room. So they've been on the bed, they recover very quickly, they come back, have a quick discussion, reiterate what we've done, reiterate the going home instructions, and most go home from there. So we haven't had to have a nurse permanently outside just for HCA because we don't have that recovery area. But equally, we're doing our procedures mixed in with a general clinic rather than a sort of almost like a theatre list. We find that works for us, so we mix them in as they come to the top of the waiting list, and really haven't had a problem. And the vast majority do go home. Occasionally, if there is an issue, there is a small recovery area that is staffed within our general clinic. So no, it works really, really well.
Great, thank you. Another query here about what is your policy for endometrial biopsy? I'll go to Mr. Scott to start with for this one.
All of our patients have had a pre-procedure ultrasound scan to exclude other pathology, so I think that is important. A number of the patients may have had a pre-procedure hysteroscopy in the outpatient setting in part of the workup for heavy menstrual bleeding, where they may have had a Pipelle biopsy performed. If they haven't had a hysteroscopy beforehand, then it is mandatory that they all have a hysteroscopy before performing the NovaSure, so make sure you know where you are. We do Pipelle biopsy most of our patients, but I don't think it's mandatory. So if it's somebody who's under 40 with heavy bleeding, no intermenstrual bleeding, no red flag symptoms, we don't necessarily Pipelle biopsy absolutely everybody, but through the process, a lot have had it.
Great. And Mr. Underwood, what's your experience?
We offer a Pipelle to everyone. Just as a routine. If they don't want it doing at the time, then we will do it just prior to the ablation. That's just our local policy. Up until the NICE guidance came out, everyone had an ultrasound scan as well. With the new NICE guidance, we do see and treat HMB clinics. So the patient will come through, have a pelvic examination and a hysteroscopy, and then if she wants to come back at a later date for a NovaSure, we will. And in that group of patients, they wouldn't have an ultrasound scan. If they've not come through the one-stop clinic and had a hysteroscopy already, then we will arrange for an ultrasound scan, but normally the GP's done that. But we don't routinely, for the hysteroscopy, we're doing that at the time of the fundal block anyway. So I wouldn't hysteroscope someone and then bring her back 2 weeks later for NovaSure. I would just get on and do the procedure. But there's two routes in, the one-stop HMB clinic, and then there's those that come from the general gynae clinic. But I wouldn't do an ablation on the same day as seeing them if they were a one-stop patient, because they need time to consider fertility, make sure, because it's a definitive procedure.
Great, thank you. Another question about dilation. So, Mr. Underwood, you mentioned that the majority of patients you treat in the outpatient setting, so you mentioned 95%. So those patients that are not suitable, the question was around cervical stenosis, to say, you know, how would you overcome that, or would these patients not maybe be suitable for an outpatient setting? So, Mr. Underwood, we'll come to you first.
So one of the questions was about misoprostol. So we don't use misoprostol at all in this group of patients, and never needed to use it. The analgesia is good and the cervical block is good. If the cervix is really stenosed, then we have these green plastic Oz finders, which is slightly tapered, which is quite good. If you can get one of those through, then you can normally dilate up. If you're really struggling, then I'll use a white needle on the end of a sponge holder and wiggle that through the Oz and then the Oz finder, and then I manage to dilate up. I don't dilate beyond 6, or else you'll get gas leak around the side. And if you do them under general anaesthetic, you'll find they're easier to dilate, but you're higher rate of perforation under general anaesthetic compared to local, because the patient can feed back to you under local. And also under a GA, the uterus seems to relax and you do get more cavity fails where it leaks, and you often end up having 2 valsellums on the cervix to stop it leaking. And then one of the points is I used a triple tooth valsellum on all of these patients. I don't use a single tooth valsellum, because it tends to tear the cervix, the single tooth does, whereas a triple tooth will give you good traction on the cervix.
Great, thank you. And Mr. Scott, do you have anything to add from your experience?
So I don't think cervical stenosis is a rate-limiting step. Cervical stenosis often is as easy to deal with in the outpatient setting as it is under an anaesthetic, and most of our patients are dilated under direct vision with vaginoscopy and knowing where you're going and then dilating from there. The ones that are most difficult are the patients that actually find a speculum examination more tender and more uncomfortable, or psychologically more tense. And those patients who suggest that smear examinations are very difficult and something that they don't cope very well with, maybe the ones should be screened out. But cervical stenosis, nulliparous patients really haven't been a problem. And I'd agree with Martin that the gas test is much easier to pass in the outpatient setting without the general anaesthetic and the relaxation of the uterus. We've occasionally had some failures in a theatre setting, and they then tend to come to my clinic in the outpatient setting, and they pass the gas test without an issue. So again, that's a real positive.
Great, thank you. Another question here, were all of the pain scores 2 to 3 out of 10, or was this the average? So this is relating to your presentation, Mr. Underwood. And what was the parity of the 100 first women? Would you recommend patient selection for the initial clinics? So obviously we've kind of touched on that with those that you may feel might be more challenging, or how to overcome that.
So patient selection is important. So you need to counsel your patients appropriately. So if you don't counsel your patients, they will come back and then they will haunt you forever. So my first ever day case TLH was a lady who had chronic constipation. I did her as a day case, and then she bounced back the next day because I hadn't thought about the bigger picture that the constipation was the other issue there. So it's all about counselling a lot of these patients. We do previous caesarean sections. There's no limit on that. We don't do classical caesarean sections, or if they've had a previous perforated uterus, we would avoid that group of patients. The haematology team have cottoned on that we're doing ablations and patients are happy, so they seem to send us lots of the young women who are on warfarin or apixaban, so we'll ablate those. The apixaban will stop it 24 hours before the procedure, And if they're on warfarin, it depends why they're on it. We'll either stop it for the 5 days or we'll bridge them over to tinzaparin to do the procedure. What was the rest of the question, Sarah?
It was just, I think around what was the parity of the 100 women? So you mentioned that you do get some younger women as well.
Yeah.
Oh, sorry, parity, but as far as I suppose, like C-sections you mentioned.
Yeah, we've done sections. We've done some nullips. We'll have done some grand multips. I think the most sections I've done is 4 previous cesarean sections. And there's a Mayo paper that had women who'd had up to 6 cesarean sections, if I remember. So that we don't do that.
One outlier.
And then someone asked about scanning the lower segment. So we don't routinely scan the lower segments at all. So we just carry on with the ablation. The ablation device is tapered, so you get less energy at the lower segment. And if there's less myometrium there, then the machine can sense that as well. So we don't adjust the length of the NovaSure. We just believe in the technology. And we've not had any problems yet.
No, absolutely. And we've had 3 million women and we haven't had any problems. So absolutely, we can speak to that. Mr. Scott, do you have anything to add with any of those comments?
No. Well, I'd agree with the caesarean sections. It's not been an issue. Most of the time, the caesarean scar is actually within the cervical canal. When you look, you can just see the niche there, and it's only the very tip of the NovaSure device that comes anywhere near it. So it's not been a concern or a worry for us. And we're very happy to do nullips as well as multips. They're equally well tolerated and both do well. It's more the psyche of the patient and the patient being keen to proceed in that outpatient setting rather than it being practically difficult. It's not really been a problem at all.
Great. We've had quite a lot of questions about contraception, fitting an IUD post-procedure, or also thinking about lap steries possibly. How do you manage those sort of options, and what do you offer your patients for contraception? We'll go to Mr. Underwood first.
So contraception, we use Mirena particularly if they've got dysmenorrhea, adenomyosis, those types of symptoms, pelvic pain. So the Mirena will help in that group of patients. If they don't want that, then we'll offer a copper coil. The main thing to bear in mind is the Mirena or the copper coil need to go in straight after the ablation has been done. Around about 6 weeks after. I've hysteroscoped one lady 6 weeks post-ablation, and the cavity was started to contract down already, so you'll struggle to get it in at a later date. Also, warn the patient that Mirena needs to come out in 5 years' time, and you'll be unlikely to get another Mirena back in because the cavity contracts and scars around that device. So if they were a younger patient, that Mirena will give them 5 years of contraception. In 5 years' time, they need to be thinking of something else, like condoms. Vasectomy, we try and encourage, or staying away from the partner. The copper coils are a slight advantage that some of the copper coils are licensed for 10 years. You get slightly longer level of treatment there. But we make it clear it's on our consent form and it's in the leaflet that they must never try and get pregnant after this. This is a definitive procedure and they must use some form of contraception. So that's what we advise all our patients. But Mirena, copper coil, condoms, or vasectomy is the way forward. Mirena is very good, particularly if they got the dysmenorrhea.
Oh, absolutely, and we'll cover that in the webinar that's coming up on the 8th of October as well. And Mr. Scott, do you have any thoughts around contraception and counselling?
Yeah, I mean, the counselling is key. They must have completed their family, and they must know that they need to take effective contraception. Likewise, we're happy to put Mirenas in at the time of the procedure. There's not a high uptake of that, but for those Mirenas we've put in, there's not been a problem with removing them at the end of 5 years. They've come out quite easily, and there was a concern that with the adhesions in the cavity it might be an issue. And we've not really had an increased infection rate with a foreign body being within the cavity either. Some patients, partners have vasectomies or condoms is allowed. I know their overall fertility rates will be less, and since we've been doing this, I can't think of any pregnancies that we've had, fortunately, post-procedure. So it's not been an issue. Obviously, if it's under general anaesthetic, they can have a laparoscopic sterilisation. And we used to put in the eSure coils when they were licensed and before they were taken away as a dual procedure, which worked well, but obviously not relevant anymore.
Mr. Underwood, you had another comment there.
I've forgotten.
It might come back to you. That's great. Well, I think that's covered the majority of the questions. We will follow up if we didn't get a chance to answer those. But just to conclude, if you do have any questions or require any further support, then please do reach out to your local Hologic representative, or you can email us on ukgynsurgical@hologic.com, and you'll find some additional resources on gynsurgicalsolutions.com. So a big thank you to both Mr. Underwood and Mr. Scott for presenting this evening and sharing your experiences. And thank you to you for joining us. And I know there's many of international participants this evening as well in different time zones. So I hope you found it useful. So thank you so much, and hopefully we'll see you again soon.
Thank you.